afternoon, everybody. My name's Bronwyn Edwards from Roses in the Ocean, and with me is James.
Hello.
Welcome to the feedback loop for the co-design of the Safe Space Hub for the Redcliffe area. So it's really nice to be with you today. Firstly, we'd like to acknowledge the traditional owners of lands on which we're all gathering today and pay our respects to elders past, present and emerging. And we'd also like to acknowledge people with lived experience of suicide. For those of you who've been part of this co-design process so far, thank you so much for bringing your insights and your perspectives to this process. They're incredibly important. And to anyone else who's going to be watching this webinar with a lived experience of suicide, and for all those in the community in which this Safe Space Hub is going to make such a difference. We acknowledge everything that you bring to suicide prevention. So today we're going to run you through where to from at the moment, what we've heard so far. So bear with me while I just share my screen with you and we will get underway. All right, so as I mentioned, it's the first feedback loop and it will be accompanied by a survey as well, which we really encourage everyone to fill out and to share with other people with lived experience to do the same. So just to orientate you to where we are in the process, we've run a number of lived experience focus groups and we've brought all of those people together into a whole of group session just with people with lived experience of suicide. And then this has brought us to this feedback loop now, this webinar and survey. In parallel with this happening at the same time, we've had some focus groups with health professionals and other stakeholders as well. And later today, we are providing their first feedback loop. And then from all of those, we'll collate all of that together and that will feed into the health professional group session. And then further on to more feedback loops and a combined session as well. So here we are today though, where this red circle is. So in our focus group sessions with people with lived experience, we really wanted to explore the feelings and emotions around what it's like to actually access support when you're in significant emotional distress or suicidal crisis, and particularly what it's like to access that support through the emergency departments. Also, though, just as importantly, if anyone was also in a position where they choose not to access ED, what are the feelings and emotions that they are experiencing not wanting to access that service? We then also wanted to understand what are the needs of people when they're needing to access support, and how do we need to meet them? What are the ideas of being able to meet them? So to start with, feelings and emotions, we looked at the various touch points of accessing help through ED, and that's about, there's that finding stage when you haven't actually gone to the ED, but you know that you're in a position where you really need some additional support. Then we talked about arriving and that initial assessment or triage phase, the waiting period, the treatment, and then leaving. So they're the different touch points that James and I'll run through now. You'll see in the quotes, anything that's in a blue outlined quote is someone with a personal experience of suicidal crisis. And those in a red outlined quote is from someone who's got the experience of caring for someone through suicidal crisis. So feelings and emotions at the time of finding. We were told that people were feeling overwhelmed, scared, desperate, confused and frustrated, powerless, worried, concerned, hesitant, and feeling a lot of anxiety. Just to pull one quote from each, I'm really, really scared because I don't know where I'm going to go in this escalation. I don't know what's going to happen. It's a really scary space to be sitting in. And from a carer's perspective as a parent, I felt worried and consumed. So the emotion is fear and extremely concerned.
Thanks, Bonnie. I'll have a go. And certainly for those that are online, thank you and welcome for joining us. For those who are watching this as a recording, by all means, slow it down and have a look at each individual quote to see what the lived experience individual shared with us. So the arrival and initial assessment period that we're walking through in terms of that touch point, what you can see here on the left-hand side in terms of what were you feeling, hope that I'll get help, helpless, powerless, abandoned, been rejected, sense of desperation and anxiety. And from someone with a personal experience of suicidal crisis, I've always avoided going to ED, but a few years ago broke and went, and it confirmed it wasn't the place for me because I felt like a stupid child. And you go, why am I here? And from a carer's perspective, one example was there's nothing I can do because they have the power at that point. They're the people that are going to take us in. It's like being in a prison and you're in prison guard and you can't speak to them about it. You just have to take it. Thanks, Bonnie.
When we explored the feelings and emotions when someone's waiting in the ED to be seen, people express feelings of helplessness, feeling distressed, scared, overwhelmed, anxious, worthlessness, frustrated, but then others on the positive side are grateful, just being grateful to be safe. So from a person who's experiencing that suicidal crisis, there was a lot of movement around me, which was distressing in itself. Just the busyness of the ED area, all that sensory stuff is really full on, and trying to manage my family's reaction alongside that is really scary too. From a carer's perspective, when I'm taking my daughter and we're standing at the window, she's very unwell, and I'm trying to talk privately through a screen with all these people in the waiting room, it's just as stressful. It's not the place to have those conversations. And then you get desperate thinking they're not going to take us through. So you start trying to sell your story.
So in terms of the next touch point, the treatment, what were you feeling? A sense of anger, helpless, unimportant and frustrated. Too many assumptions that lay the blame on the individual. Not believing people seems to be the main thing I noticed. You have to quantify and jump through hoops. From a carer's perspective, helpless because where do you go? If it is where you're meant to go when you're in crisis, where else is left? There's nowhere else to go.
We then spoke to participants about what it's like to leave ED. They said they felt frustrated, worthless, distressed, but if it had been a positive experience, then it was uplifting. Someone talked to me for 10 minutes and told me I don't have a mental illness. It really messes with my head. It's very distressing. And that was shared with us by someone who does have a diagnosed mental illness. From a carer's perspective, it's about being listened to. It could be something as simple as someone heard their request for a medication change, but it usually doesn't get that far. And I'll just share that other one from a carer's perspective, saying how I'm feeling is completely dependent on what you've received and whether you're going away thinking something has changed for the better through this traumatic experience that you've just had.
So Bronnie mentioned earlier that we also had the conversations with those suggesting that if they hadn't used the ED or chosen not to attend, and here's some of the responses. A sense of feeling exhausted, infuriated, frustrated and disappointed. And why were they feeling this way? That's definitely a place I won't ever be going again. I don't trust it. And from a carer's point of view, there have been a lot of closed doors. It's been hard to get her to present to ED for any help because it does mean sitting in a room with a whole heap of people that she knows because it is a small community here.
So then we asked people to really look at what are their actual needs and what are their ideas to meet them. And we broke it into a number of different categories that we explored. We invited people to Blue Sky Dream because it's super important that we do have that opportunity. But at the same time, we're also able to explain the specific parameters exist around this particular co-design process, the funding envelope, the time, those sorts of things. But it's important to capture that blue sky dreaming because as the services are open for longer, you never know what's around the corner in terms of further support. And it's really helpful to be able to always go back to that blue sky dreaming to see what else can this service now offer when you've got the capacity to offer more. So when we talked about location, there was a need for physical safety. in terms of the blue sky dreaming, people with lived experience of suicide were asking that it was away from ED, not on hospital grounds. But if it did have to be on hospital grounds, a new building that doesn't look like the hospital. We know that in Brisbane North here, though, there is no requirement for these to be on hospital grounds. People asked that it would be walking distance from the hospital in case there is a need for medical attention, if somebody wants to go up to the hospital, that it could be near a library or an arts centre to connect with other parts of the community. And other location ideas included in a shopping centre, in an arcade near the jetty, the showground area, neighbourhood centre, in the GP super clinic, near the Botanical Gardens, near Centrelink, Red Cross Centre, Blue Water Square. So lots of ideas from those who live in Redcliffe and know the area well. And another comment was that it needed to be an independent area that was not associated with the hospital.
So thanks, Bronnie. In terms of some inward connections and the needs and ideas to meet these, in particular this sense of to feel welcome, and again, picking up the blue sky dreaming approach, an ambulance and police can drop people off if need be. Peer workers can go to the ED and pick people up. Carers, families, support workers can all bring people in and maybe even stay with them if wanted. And a pathway in from ED if a person has gone there first and give that support.
Then we also looked at outward connection. So what role does the Safe Space Hub have in being able to connect guests of the service to additional supports outside of the safe space? So needs highlighted were to feel that there's something in place so I'm not going back to the exact same position or feeling worse after. A need to have a plan, getting some sort of direction for the future, practical referrals or connections, collaborative planning, information and resources, phone numbers, appointments, continuity, people looking for follow-up to make sure that the connection was actually helpful, and help with practical things like signing up for Centrelink or finding a doctor. In terms of blue sky dreaming and ideas to meet those particular needs, consultation with community groups so that peer workers are really well informed to be able to refer and link people with appropriate services. So to have access to an up-to-date community directory and just good relationships there. Resources for people to get information on mental health and suicide prevention services. That someone can bring a guest to the hospital if they need or want to go, so that peer worker could take somebody up there. Closely connected with other services and know whether they have capacity to take people on. So current knowledge and good relationships, that's building off that first point again. Follow up, people suggesting a phone call a day or two later after someone's been a guest at the safe space. It's important that people leave with extra information than when they turned up, and that they're able to refer to services for relationship issues, financial issues, chronic pain, emotional pain, grief, all those other things that we know are contributing factors to suicidality.
So in terms of the service model itself, a sense that the needs required is that it has to be believed, this idea that actually is going to be believable and workable. A feeling of self-worth, to be cared for, encouragement, validation and to be taken seriously, to be seen quickly, a sense of reassurance and a preservation of dignity. In terms of blue sky dreaming, don't have to fill in forms on arrival. Information is all voluntary or gathered informally through conversation and non-binary options available as well. Enough peer workers to do a warm welcome on arrival, a sense or offered tea, coffee on arrival, water, individualised care and choice for the guests to speak to someone straight away, an assessment if they want. Communal events, a barbecue on a Saturday night, for example, and group sessions. Appointments available for people who want to speak to someone at a specific time. There may be an outreach component, a sense of no time limit for guests in the safe space. Tactile activities available. Carers are welcome. Voluntary feedback through a QR code when leaving. And don't have to do a safety plan.
With regards to staffing and workforce, the needs that the people with lived experience of suicide identified was that there'd be someone to check in regularly to not be left alone. So enough people there that there are a lot of touch points. Connection with someone to reassure you that things will be okay. To speak with someone with a lived experience of suicide. A peer worker who can use skills and training to quickly build rapport, and someone who really understands. So in terms of Blue Sky Dreaming, to meet those identified needs, a diverse peer workforce with wide array of experiences and skills. Enough staff to manage busy nights, that staff are trained in mental health first aid, cultural competency, working with youth. So really well-trained, very comprehensive training for the peer workers. Purely peer-led, that peer workers are supported and have knowledge to direct people to specific services. That staff have a dedicated time to do follow-up calls while the space is closed and no one's coming in. So just looking at that rostering, and really close connections with other services.
Thanks, Bonnie. The physical environment that needs this sense of physical safety, a space where I can take a breath and just regroup. Calm, quiet environment. Maybe the option for privacy or calm open space, and soft and quiet. In terms of Blue Sky Dreaming, lots of plants and greenery, open communal spaces and areas for privacy. Maybe there's a section with beds where people can rest, an area for children, the ability to move furniture and privacy schemes around and change the space to fit the needs. Residential house does not look clinical or administrative. A separate sensory rooms, a kitchen where you can make a cup of tea and some food, sturdy and comfortable furniture, an outdoor space with barbecue facilities and separate smoking area, soft colours and furnishings, and non-gendered bathrooms.
From an accessibility standpoint, a need for information about where to get a drink, where the toilets are, to feel welcome, and to know what to expect. So information in community so that people know what the safe space offers. From a Blue Sky Dreaming perspective, ideally people would love the service open 24/7. People understand at this point in time that that's not going to be feasible with the resourcing levels. So we asked when, if you can't be 24/7, when would you like it open? Late evening or overnight, weekends and weekend nights, preferably on the ground floor, but if not, it must have a lift. Plenty of parking. Taxi vouchers available for people who either need one to get to the safe space or people need one to go home. Close to public transport. Privacy, so that people feel comfortable to speak freely without fear of judgment. And a contemporary environment contemporary environment and branding to help normalise it and present the safe space as an innovative place and not associated with the ED. A warm and welcoming space for everyone while maintaining safety, and that people can stay as long as they need to. So then we also asked people to just start thinking about core values for the safe space hub in Redcliffe. So these need to be worked further, and we will do some more work throughout the co-design process, because ideally you want to condense this down to sort of 5 or 6 core values. But at this point in time, people have identified values like respect, dignity, authenticity, truth, integrity, kindness, non-judgmental, cultural diversity, acceptance, understanding, validation, follow-through, deep listening, confidentiality, and trust. So next steps from here, this webinar, a link to this webinar will be made available later today, and there's also a survey. So we ask that we'll send the survey link and the webinar link to everyone who's been involved in the process so far, and to the PHN and to the various services that are connected with this co-design, and ask that that gets distributed far and wide. For anyone who's online here now, anyone that you know who lives in this catchment area who has a lived experience of suicide, please send them this information, because it's an opportunity for them to actually participate. Have a look at what's been said so far, add any comments, add anything else, so that they're actually taking part in the process. So this survey will close on the 6th of October. A week later, it will be followed by the group health professional session. And then there'll be another feedback loop on the 19th of October. Then we'll bring equal numbers of people with lived experience and health professionals together for a combined session face-to-face on the 28th. And then that's followed by another feedback loop. So that's sort of where to from here. We really, really thank you all so much for joining in. Those of you who've had the time to join us today, that's been wonderful. Really, really looking forward to your feedback. Make sure, we'll just come back to screen now. Have a good read, take your time to go through it. It's your chance to sense check. Have we heard you correctly? Have we captured it well? And anything that you've thought of since those sessions that you've had with us, this is a chance to add to that as well. I'll just come into the chat just to see if there's a couple. So from someone here, they've just locations near the jetty. This wouldn't work for Murray people as it has a very negative history. Okay, thank you for letting us know that. So we'll take that into, we'll pull that through into the notes as well. All right, so look, that's it from us for now. Thanks so much, and we look forward to seeing you at the next session.
Thanks, guys. Bye.